Bonjour, je suis le visage d'Alpha 1.
We are the faces of Alpha One.
I am the face 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 of Alpha One.
Je suis le visage d'Alpha 1.
I am the face of Alpha One.
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 I am the face of Alpha 1 antitrypsin deficiency.
Good evening, everyone. Thank you for joining us today. For those of you that I have not yet had the pleasure of meeting, my name is Angela Diano, and I am proud to be the Executive Director of Alpha One Canada. In the next hour, I hope to provide you with an overview of where our organization is at in working towards our mission to ensure all severely affected Canadian Alpha 1 patients have equal access to augmentation therapy, the only specific treatment for this rare progressive genetic disease. I'm going to make some introductions before I debut our Access for Alphas short film and bring in Dr. Ken Chapman to discuss the historical challenges that the Alpha 1 community has had in getting access to treatment here in Canada. I will be then sharing our new campaign microsite and making the official launch of our Access for Alphas campaign. I would like to begin this evening by acknowledging the Indigenous peoples of the lands that we are on today. While we meet today on a virtual platform, I'd like to take a moment to acknowledge the importance of the lands which we each call home. We do this to reaffirm our commitment and responsibility in improving relationships between nations and to improving our own understanding of local Indigenous peoples and their cultures. From coast to coast to coast, we acknowledge the ancestral and unceded territory of all the Inuit, Métis, and First Nations people that call this land home. Please join me in a moment of reflection to acknowledge the harms and mistakes of the past and to consider how we can each, in our own way, try and move forward in a spirit of reconciliation and collaboration. I'd like to thank the many brave faces of Alpha 1 who participated in our patient videos, one of many which was shown during our opening video just now. Patient testimonials about living with Alpha 1 antitrypsin deficiency and patients' experiences with access to treatment uncertainties certainly underscore the advocacy work that Alpha 1 Canada is committed to achieving. I would like to encourage Canadian Alpha 1 patients watching this evening to consider sharing their patient journey with us to support our advocacy work. Your testimonials put a face to this progressive genetic disease and illustrate the burden of disease that our Canadian health ministers are reluctant to fully comprehend. If you'd like to help our advocacy efforts by sharing your story about living with Alpha 1, please contact us at info@alpha1canada.ca, and we will certainly guide you through that process. I'd like to begin by introducing you to my colleague at Alpha 1 Canada, Jessica Cook. Jessica has been with the organization now for 3 years. She is a registered nurse, and she's often the first point of contact for patients reaching out to Alpha 1 Canada. Jessica and I will be hosting some informal Zoom meetings over the summer for those interested in sharing their patient stories. So please do reach out to her if you would like to learn more. She will be co-moderating this evening's session with me. So if you have a question or a comment that you would like to put into the chat function during the next hour, she will be monitoring the chat room. Hi, Jessica.
Hello, everyone. Thanks for joining us tonight.
Alpha 1 Canada has been developing a campaign in recent months since getting the exciting news in February that after many years of lobbying for an augmentation therapy category for the potential addition to the Canadian Blood Services Plasma Formulary, the provincial and territorial governments have finally agreed to permit a review which will commence this summer. Before I go into where we are at in that process, potential timelines, and how you can help, I would like to introduce Megan Watson with the Alpha 1 Canadian Registry. I think it goes without saying that it is you, the patients, that ultimately demonstrate to our health ministers what the patient need is in the Canadian Alpha 1 community. A patient registry can be a powerful tool to observe the course of the disease, to understand variations in treatment and outcomes. So we are incredibly fortunate to work with the registry, and Megan is going to give a brief overview of how you can register if you have not done so already. Welcome, Megan.
Hi, everyone. Thank you, Angela. My name is Megan. I'm the coordinator of the Alpha-1 Canadian Registry. As Angela said, I'm going to give a brief overview of what the registry is and provide some information on how you can enroll in the registry if you are not already signed up. So what is the purpose of the registry? The registry was established by Dr. Chapman in 1999. It is a confidential database of information about Alpha-1 patients in Canada. Its purpose is to gather data about individuals with Alpha-1 so that researchers and doctors can better understand why some people remain healthy and free of lung disease while others develop emphysema. Because Alpha-1 is a rare and underdiagnosed disease, it is difficult for researchers to gather enough clinical data, especially data that is specific to patients in Canada. The data collected by the registry allows researchers to learn more about the disease and may benefit other Alpha-1 patients in the future. The collected information is also very important for supporting advocacy efforts. For example, providing data to support the efficacy of treatments. We currently have over 460 individuals enrolled in the registry. However, we know that there are many more Canadians with Alpha-1 who are not currently enrolled. So we are trying to spread the word and get as many people registered and collect as much data as we can. Through the registry, we also share information about relevant clinical trials that you might be interested in, and we can help to coordinate genetic testing for family members. If you're interested in getting more information about family testing, or if you would like to join the registry, I will encourage you to take down our contact information, which is listed at the bottom of each slide. It will also be displayed at the end, but having it on the slide will give you some time to copy it down while I'm speaking. Additionally, if you have already enrolled in the registry, but you haven't heard from us in a long time, I'll encourage you to reach out and to update your contact information with me. So who is eligible for the registry? Anyone with 2 abnormal deficient Alpha-1 genes is eligible to enroll in the registry. So these are some examples of different genotypes. However, this list is not exhaustive. We don't enroll carriers, but anyone with any 2 deficient genes is eligible. What is the commitment? To enroll, there are 5 initial forms, which include a consent form, a medical release form to allow us to contact your doctor to request any test results, such as blood work, breathing test results, or chest CT scan results, and then 3 baseline questionnaires. After this initial enrollment, you will be contacted annually for a follow-up. You'll be asked to resubmit a medical release form and to complete 2 forms, a 1-page follow-up form and a standardized symptoms questionnaire. The forms can either be mailed to you along with a return envelope for you to mail them back, or we can email them to you if you're able to print them out, complete them, and then email them back to us. All of the information remains confidential and participation is voluntary, meaning that you can choose to withdraw at any time. You can find more information about the registry at our website, www.alpha1canadianregistry.com. And next slide is our contact information. So if you're interested in registering or if you have any questions, you can contact me by phone or at the email address listed here. Thank you, and I will look forward to hearing from you.
Thanks, Megan. Alpha-1 Canada is proud to collaborate with the registry, in addition to working with AlphaNet Canada and Inamar's Prolactin Direct program. For a rare disease, Canadian Alpha-1 patients are incredibly fortunate to have multiple services that work collaboratively in order to best meet the patient need. It probably will not surprise many of you tuning in today that Alpha-1 Canada hears from families across the country living in a constant state of anxiety because an Alpha-1 patient either cannot commence treatment when prescribed it because they do not reside in Quebec or British Columbia, or more than ever, a patient who experienced firsthand the benefits of treatment has received notice that their access to the treatment is being terminated by their insurer due to a change in the healthcare insurance. The inequities in coverage are not unique to publicly funded healthcare. The landscape with private healthcare insurance is rapidly changing as well. That all being said, augmentation therapy for Alpha-1 patients is a plasma protein replacement therapy, which is a blood product. And here in Canada, blood and blood products are to be equally available to citizens that require them by our nation's blood operator. During our live stream event in 2019, we gave patients a progress report of where we were at in our advocacy efforts. So I'm going to give you a quick review and an update of where we stand with that today. Unrestricted access to augmentation therapy for alphas is what Alpha One Canada has been laser focused on now since 2017, because there is no rational difference between augmentation therapy and the other plasma-derived products that Canadian Blood Services distributes. As most of you know, tuning in, augmentation slows the progression of lung destruction by replacing the deficient protein, and yet, it is the only plasma-derived product for a chronic genetic disease that is not uniformly reimbursed across the country. Evidence-based clinical practice guidelines from the Canadian Thoracic Society, the American Thoracic Society, the European Respiratory Society, and the American College of Chest Physicians all recommend augmentation therapy for the treatment of patients with severe lung disease due to alpha-1. Their guidelines are all based on the totality of the evidence, scientific understanding of the disease, and correcting the biochemical defect. That being said, Alpha One Canada has been appealing for a category review since 2017 in hopes of getting equal access to this plasma-derived therapy for all severely affected Alpha-1 patients. Provincial governments, however, cited several different reasons over the last 4 years as to why they would not permit a category review for the CBS formulary. We were told first that augmentation therapy is not transfusion medicine. Then we were told that the treatment was not cost effective. Then we were told that the CADTH rapid response report recommended against it. And then we were told that a new category on the CBS formulary always results in overutilization. Therefore, there was reluctance to add a new category to the National Blood Systems formulary. Augmentation therapy for Alpha-1 patients is transfusion medicine. It has not negatively impacted the 2 provinces that provide it. It most certainly is not overutilized, and most importantly, both the CADTH rapid response report and technology review outline supporting clinical evidence. The CADTH reports confirm that robust clinical evidence is challenging to compile due to the small patient population. But as everyone knows, that is common for all rare diseases. After being given multiple excuses to why the provinces and territories would not move forward with a category review, we were then told in 2019 that because one brand of augmentation therapy, Prolastin C, is available in BC and Quebec, the provinces and territories denied a category review. Health ministers from across Canada would not greenlight a category review because the therapy was already available in the health system. This was by no means a judgment about Prolastin C. It was solely because of the criteria. So after years of delays and multiple excuses, provincial governments concluded that they would not consider a category review to include augmentation therapy with all the other plasma-derived products listed with CBS, simply because augmentation therapy is available in BC. To shut the door, citing availability in the health system is confusing to say the least, because Canada does not have one health system. Because governments would not permit Prolastin C to engage in an augmentation therapy category review for the National Blood System, due to it being in the health system already, we had to find another augmentation therapy that had Health Canada approval, but was not yet in the health system. After calling on industry partners throughout 2020, we were elated to learn this past summer that CSL Behring Canada was willing to submit their augmentation therapy, Zemera, for a category review. That said, government still balked at this route because treatment was available in BC. However, they finally approved our plea for a category review in February 2021. Needless to say, our organization was overjoyed this winter with the news, and we quickly got to work assembling an incredible team to help us bring this submission to fruition to support the CSL Behring submission to CADTH. Many of you who participated in our focus groups met some of our colleagues who are all busy collecting and analyzing the data we need to support the submission for the category review this summer. I know many of you are asking, okay, but when? When might we have access to treatment? Once the review is initiated, it will take at least 6 months before the recommendations go back to the Provincial Territorial Blood Liaison Committee and the Council of Deputy Ministers of Health. They then deliberate and will ideally have a decision around next steps by the end of the calendar year or the beginning of 2022, with the ultimate goal being access through Canadian Blood Services next spring. Will there be delays with government? Probably. Will Alpha One Canada be there reminding them every step of the way that this patient base has been waiting since 2017 for a decision? You bet. We will continue to advocate on your behalf to have an expedited review time to ensure access is attainable as soon as possible. So why are we here in Canada falling behind other countries with providing access to Alpha One patients? I will bring Dr. Chapman in on this discussion momentarily, but I did want to display for you where there is public access around the world. Our governments have stressed time and time again that overprescribing of plasma-derived therapies is of paramount concern, even though there is no evidence to warrant a concern regarding the overprescribing of augmentation therapy. I think it is prudent to note that unrestricted public coverage for augmentation therapy is available in many other countries, like the Czech Republic, Austria, Belgium, Germany, Portugal, Italy, France, and Spain. In Germany, a country with a population of over 83 million people, there are only 1,500 Alpha-1 patients on augmentation therapy. Again, nowhere is there evidence to suggest that there is overprescribing of augmentation therapy. Our health ministries are very concerned about overprescribing and cost containment, but we can actually use British Columbia to demonstrate that this is just not a concern when it comes to treating severely affected Alpha-1 patients in this country. The population of British Columbia is roughly 5.1 million people, and only 100 BC residents are currently receiving augmentation therapy for Alpha-1 antitrypsin deficiency. The message here is that in a province where augmentation therapy has been available unrestricted for over 10 years, there has not been any overutilization nor off-label use, and the cost of therapy has not negatively impacted that province. So we need that message and the patient need to be communicated to our decision makers here in Canada. And I'm here tonight to tell you how you can help us do that. And I will provide more information on that in the next 30 minutes. But first, without further ado, I would like to introduce Dr. Ken Chapman and get his reflections on these issues. I recognize most of you tuning in are familiar with Dr. Chapman, but I would be remiss if I did not mention that he is an international expert on Alpha-1 and founded the Alpha-1 Canadian Patient Registry. He is currently the director of the Asthma and Airway Center of the University Health Network and professor of medicine at the University of Toronto. Not to mention, he has been an incredible support and resource to me and our organization in recent years. Dr. Chapman, thank you for joining us this evening.
Well, thank you for inviting me. I'm delighted to participate in this very important meeting and to reach so many alphas all at once. I come unprepared with slides. I think my role is to answer questions for the most part, but maybe I'll flag a couple of things. One is that Megan made a very clear case for enrolling in the Alpha-1 registry. It's been around for 22 years, and I think we should recognize the role that it may have played along the way. Certainly research and research publications helping inform not just Canadians, but the world about how best to manage Alpha-1. But in fact, tonight's webinar is a great example of some of the work that indirectly leads back to the registry. 22 years ago, when the registry was founded, there was no place for patients with alpha to gather in Canada. We helped patient groups take shape. By the way, it wasn't just a one-off, quickly and easily done. There were stuttering starts and stops and meetings being held here and there. But because we were a registry, because we had contact information, we could indicate by mailing and later emailing that there were meetings taking place. Eventually, that gave rise to the very, very effective Alpha One Canada that you're a part of this evening. And I want to give credit to Angela for all the great work she's done. Every time she talks about trying to negotiate with government, I am glad that she's doing it. I'm not. Government is very frustrating to deal with. And I am amazed at the new wrinkles and ways that government does its best not to fund well-established medical care. I guess I have a couple of quick thoughts before I shut up, after having said, please join the registry if you haven't, and definitely support this important patient group. If you wonder why augmentation therapy isn't covered, I'll give you a quick history, the bottom line of which is you need to stop being polite Canadians and raise your voices. And I have a hunch that's what Angela may be asking you to do. If you look at how healthcare dollars are spent in Canada, they're not always spent rationally. And if you want to know where the new expensive treatments are going to go, look at what catches the attention of the Sunday newspapers when they write about health. So cancer is a scary word. Cancer research gets big investments. Lung research, not so much. And if the lung disease in question is emphysema, oh, that doesn't get very much at all, because there's this sense that, well, emphysema is something that people have done to themselves with cigarettes. Don't get me started, but this is a problem that alpha patients face. Whether or not you've smoked, you have a tremendous genetic problem that has contributed to your emphysema and/or liver disease. And the healthcare dollar really isn't spending a lot of time looking at emphysema in general, and certainly not your particular variety of it. So how do you change that? Raise your voice. And by the way, if you do make donations, hoping that it will go to research, have a close look at where you're donating. Not all of the lung-related organizations are investing and thinking about Alpha One. The quick history, it's a half century now that we've known about Alpha One, described by Swedish investigators, Lorell and Eriksson. It's been a quarter of a century that augmentation therapy has been available. That is purified, shown to be safe for infusion purposes, shown to get into the bloodstream in useful amounts, shown to get into the lung. And so for 25 years, augmentation therapy has been available for doctors in Canada to prescribe. But there was a problem, and at the root of the problem is doctors have come to view Alpha One as just another kind of emphysema. So the Canadian Thoracic Society a long time ago said, you know, we'd really like to see research done based on usual lung function measurements. We'd really like to see something other than blood tests. We'd like to see breathing measurements, spirometry. In a word, what they wanted to see was that augmentation therapy kept the breathing tests in good fit form as compared to placebo. Small problem with that. The breathing tests that we like to use aren't actually very sensitive. And it turns out, in order to do the test that the Canadian Thoracic Society wanted, would take 1,000 patients studied for 5 years. We can't do that in a rare disease. And so for 20 or so years, a great many lung doctors in Canada didn't realize that augmentation therapy was a reasonable thing to use, to think about. They didn't realize it was there for them to prescribe. And it's only in the last few years, the last 5 years, that we start to see lung doctors asking about the use of prolastin, asking about its availability, and how best to infuse it. So, a couple of suggestions for you based on the ignorance in Canada by politicians who don't invest where they should and doctors who don't know the area that they should know. The suggestion is educate yourself, find out as much as you can about your alpha-1, and be a squeaky wheel, whether that's speaking to politicians and demanding that your problem get the attention it deserves, or speaking to your physicians and try to guide them to some of the information they may be overlooking. Angela?
Thank you, Dr. Chapman. You mentioned the Canadian Thoracic Society treatment guidelines, and they support the use of augmentation therapy. We anticipate that those guidelines will be updated this fall. What updates would you like to see reflected in the 2021 guidelines that weren't there or in 2011?
The guidelines in 2012 said that augmentation therapy should be considered based on improvements or preservation of lung density and prevention of death, slowing of mortality. And I think they can strengthen those statements. We have since that time the publication of the RAPID trial that we published in Lancet, and it further underscores the benefits of augmentation therapy. I would love to see them add a great deal more. When I deal with patients who have alpha, I think some of the missing items are the need for action plans to allow early self-treatment of future exacerbations. That's when the lung gets destroyed in COPD in general, very much so in alpha. I'd like to see more attention paid to family screening. I'm typically dealing with a patient in his or her 40s or 50s. The people most at risk are not that patient's children. That's always the question. What about my kids? Kids are probably carriers. A very unlikely possibility that they have your full severe deficiency. But every single one of your brothers and sisters by the same parents have a 25% risk of having the same disorder. Docs aren't accustomed to trying to reach out to brothers and sisters. So I'd like to see some sort of statement about the appropriate family screening to the highest risk part of the family. And I'd like to see a little bit more attention paid to liver disease. We're now routinely involving a hepatologist in the care of all of our alpha patients. All of our patients get what they call transient elastography. The commercial name is FibroScan, and it helps to detect early liver problems. Very useful. And by the way, though we're not talking a lot tonight about liver disease, some liver treatments are just around the corner and they're really exciting. So this is something you want to be aware of. Liver problems can sneak up on people quietly. Unfortunately, the way the CTS works, they pose a question, go to the textbooks and the journal articles and try and sift through it all to answer those particular questions. I actually don't know what questions the CTS plans to pose. I have no idea how they're going to answer them, but those are the things that I would add to a useful CTS statement.
Thank you. We have discussed this, and as you know, the province of Alberta halted their special access coverage for augmentation therapy in fall 2019, citing lack of evidence. And you've stated time and again that augmentation therapy not only preserves lung structure, but that it adds years of life. So what do you think decision makers are, I don't want to say missing, I think ignoring in the evidence that treatment does indeed prolong patients' lives?
I think the problem is the blame belongs to a whole lot of people. As I've indicated, we've had augmentation therapy prescribable in Canada for a quarter century. There should have been an organized registry that was mandatory and funded by the company that distributes augmentation therapy. We would have a much more complete set of information about what augmentation therapy does. It was the failure of Canada's regulators like Health Canada to put in place some sort of, they call it post-marketing surveillance, and it's a lack of foresight on behalf of the distributors of augmentation therapy that they haven't thought about funding such a program. They're coming to it very belatedly. They're trying to capture a fragment of information. So that's part of it. You mentioned the provincial authorities perhaps missing some information. So let me give you a bit of background information, and this is very general. It isn't specific to alpha. The provinces spend an extraordinary sum of money on medical care. They don't want to waste it. It is a difficult problem for them. Unfortunately, they take very blunt weapons to the problem. And one of the things that they like to do is say, no, we're not going to list it. We're not going to fund it. The best way to save money is just to keep on saying no. And one of the problems with that, and yes, there are some things we maybe can't afford, but one of the problems with this no approach is that some of what happens behind closed doors. So I won't blurt out any names here, but I can tell you that when in the province of Ontario, augmentation therapy was delisted, the province went to an academic who can be quite reliably counted on to say no to almost anything. And I say, well, how do you do that? If you've done any research in the real world, you always know there's a limit to the research, there's a question left over, there's a data point that doesn't quite fit. And so it's always possible to pick a hole in somebody's presentation. It's especially easy with a rare disease because we have small numbers of patients, and it's really hard to present the results in large populations that are really robust and statistically strong. So bottom line, the provinces, when they want to say no, whether it's alpha or the newest diabetes pill or the newest heart treatment, can always find somebody out there who's willing to poke a hole in the argument, find a flaw in the data, and say, oh no, that doesn't work. I don't mind that so much, but they do it behind closed doors. I know who reviewed the Alpha-1 augmentation therapy file that many years ago, but I'm not meant to know. It was done in secret. I think as consumers of the healthcare system, and trust me, as I'm getting older, I'm more and more aware of this, I'd like to know who's making these decisions and on what grounds. I'd like to see it brought out into the open. I think there's some very strong arguments to be made. And again, people with COPD in general, people with alpha in particular, have had their arguments ignored and too many decisions made behind closed doors.
I would agree with that. And you've been in enough meetings with me where transparency is just not, it just doesn't exist. You did mention Ontario, and in 2011, they recommended against funding Prolastin, and their decision stated that it had not demonstrated meaningful clinical benefit nor value for money. So how do you reconcile their statement that treatment does not provide value for money?
The cost benefit analyses are always problematic. And for alpha, it's a special problem. I really don't want to get into a discussion of qualities, etc. But what is often done when evaluating a new intervention or a new drug is to figure out how many lives might get saved or how many lives might get extended, and then how much the treatment would cost to get you there. And there are some arbitrary figures, $50,000 per quality, and you're allowed to move forward. And if you cost more than that, you're not going to move forward. And they change the number from time to time. One of the problems is, by definition, when you've got a rare disorder, you don't have economies of scale in terms of producing a treatment. And so for rare disorders, interventions and treatments are always expensive. And when it's a blood-related disorder, and what you've got to work with are blood elements from transfusions, or rather blood collection, it's especially expensive. So what I would say is the cost to treat somebody with hemophilia per year is about the same as the cost to treat somebody with alpha-1.
Yeah.
Alpha-1 is in the same ballpark as other disorders that are similarly rare and similarly related to blood products or blood constituents. And unfortunately, we get treated with a difficult yardstick. I've come to realize lately, one of the problems is when you say to, whether it's another lung specialist at a meeting or a provincial payer, alpha-1 antitrypsin deficiency emphysema, all they hear is the word emphysema, they hear COPD, common lung disease, and they bring all their lessons from that disease to alpha-1. That's not alpha-1. Alpha-1 is a rare disorder of a blood constituent that isn't there in protective amounts. Different problem altogether. So alpha needs to be put into a special category in those cost-effective evaluations.
Could not agree more. So who's doing it right? What country do you think has the most progressive access to treatment for alpha patients that we could look to for guidance or model after? Who has this right?
Well, I don't know if anybody's perfect, but there are a whole lot of people who have it much better than Canadians do. So let me just start regionally and I'll expand from there. We're always looking at the American healthcare system. We go, oh, those people and the uninsured, and is it terrible? And people go bankrupt in the United States because of healthcare. Alpha-1 antitrypsin augmentation therapy is widely available in the United States, covered by Medicare, Medicaid, through the Veterans Administration. It is far more available in the US than it is in Canada. By comparison, we should be ashamed. If we expand through the Americas, I've been lucky enough to make some lovely trips to Brazil. I meet my colleagues in the pulmonary field, some of them who trained with me, and discover that in Brazil, alpha-1 is recognized as a genetic problem. You're born with it, you're stuck with it. And as somebody who's disadvantaged by genetics, the Brazilian legislation says, so we're going to make sure you're treated properly, you have access to augmentation therapy. And there's an interesting scenario where people are documented by their physicians, they go to a magistrate, a judge, some legal setting, and the form is signed and they are now qualified to receive augmentation therapy provided by the government. So look at Brazil. It is a developing nation. It is not a G7 nation like Canada, but they just say, you have a genetic disadvantage. We're going to guarantee your treatment. In Europe, the access is expanding. Germany has always had good access. They've had good patient care centers. Italy and Spain have come on later, but have the view that people with alpha-1 antitrypsin deficiency, if they're seen by a specialist center that understands the disorder, warrant therapy with augmentation therapy if the specialized center deems it so. So you put up a map earlier, the number of countries that look at this and expand access or allow access is growing. Meanwhile, in Canada, we're retreating. We're retreating because of this strange balkanized provincial system where in Ontario in 2011, they can say, let's buy impractical orange helicopters that you can't do CPR in so that Orange has something really slick to brag about. Oh yes, and let's hire water ski instructors. We got to save the money somewhere. Let's delist Prolastin. We really do have to have some sort of coherent view for rare diseases. And alpha-1, an important lung disease from alpha-1, that's a rare disease.
I would be interested in getting your take on whether you think the GINA, the Genetic Non-Discrimination Act, has helped alpha-1 patients or not. It was passed into law here in Canada, protecting individuals from the use of genetic test results in areas outside of medical care and medical research, such as insurance. So insurers cannot use or demand genetic testing as a condition of coverage. So moving forward, how can we ensure that severely affected alpha-1 patients can get access to treatment without having to disclose the results of their genotype?
Here we may differ. I'd actually like the genotype to be used. And I think the insurance companies have taken a very poor approach to this. They've just said, please don't send us genetic information. The risk is that without genetic information to nail down exactly what the disorder is, we will see people who don't need augmentation therapy get augmentation therapy. I know that one of the questions to come up in the chat is about carriers and augmentation therapy. Happy to tackle that at the time, but without using genotypes and relying solely on serum levels, we may inadvertently misprescribe and squander a scarce resource. The other issue, though, is a little more complicated. I think I can try and say it succinctly and without using too much doctor jargon. With the common form of alpha-1, the ZZ or ZZ deficiency, there are low amounts of alpha-1 protein circulating in the bloodstream. So you measure it, it's really low. That one's obvious. There are tricky ones, though, and there's an F, as in Foxtrot variant, where there is circulating protein, but it's abnormal. It can be measured in a blood lab, but it doesn't do anything. It's not helpful. It's not functional. Somebody like that approaching an insurance company would have blood levels that are above what the insurance company is willing to accept. And without knowing the genotype, the insurance company really can't make an informed decision. I have a situation like that right now with a patient. I expect to be arguing with the insurance company. And I'll point out that insurance companies make up their own rules, and they don't make up their own rules with the help of experts. And in Canada, there's an additional wrinkle. If you wanted to know what an insurance company's rules are in the United States, you can look them up online. If you want to find out in Canada, they won't tell you. So if you want to know what the official lower limit of the serum level is that's acceptable to an insurance company in Canada, they won't tell you. I mean, we can guess from the various answers we get and narrow down the range, but insurance companies behave like a law unto themselves. By the way, if there are people in the audience who've ever been turned down for coverage, I would urge you to have the file looked at by somebody who knows alpha, because there are often some very strong arguments to be made to obtain coverage.
Yeah, and we see that time and time again. It's a little more work and a little more time, but to your point, I don't want to call them workarounds, but it's just that the insurer, the payer, doesn't have an understanding of the disease. And they always say no first. It tends to, right? They rarely say yes first. Jessica, any questions that you wanted to either ask Dr. Chapman or myself from those who are tuned in tonight?
Yeah, we actually have a question here about MZ individuals who receive augmentation therapy in the States, and why would the registry not register and track these carriers in addition to the other alphas?
I'm going to disagree. MZs are not getting augmentation therapy in the US, or if they are at all, it's by mistake. And I say this because one of our great colleagues, senior statesman in the field, Sandy Sandhouse, and you may have met him on one of these webinars. Sandy and colleagues from the US wrote a paper 10 or so years ago in one of our big journals called Chest. And they were saying, you know, we're worried about this. Carriers don't need additional protection. Their circulating serum levels are already above the protective threshold, so they're good. But we're afraid that because their serum levels show up as being abnormally low on routine testing, they might get placed on augmentation therapy inappropriately. So that's part of my answer. I'm not sure where the MZ information came from, but I believe it's incorrect. MZs are not supposed to be getting augmentation therapy anywhere in the world. To the second part, why don't we keep track? And I've wondered that myself, and I've wondered about keeping track of MZ patients, but we see so many of them. And I guess a justification right now is that's 2% of the population. Multiply 36 million people by 2%, that's a whole lot of people to keep track of. And our basic message to carriers is, please don't smoke, please don't do bad things to your liver, but if you don't do those things, you're fine. And so carriers have no real risk of disease. If they want to, they could and perhaps should check their spouses as they have children, just to see if their children are at risk. But we don't think about treating carriers.
You have another question, Jessica?
Yeah, I'm just wondering, a patient from Quebec emailed us to inquire about a CBS augmentation therapy category. How would that affect access in the province of Quebec?
Great question. So in Canada, the National Blood System does not include Quebec because Quebec has their own blood system through Héma-Québec. And right now, access for Alpha-1 patients in Quebec is through RAMQ. However, we did find out at the, it was probably December, end of December, that Héma-Québec is interested in listing augmentation therapy on their plasma formulary for the province of Quebec. So that will be a shift. It will not affect access for patients in Quebec. It will be a shift onto the Héma-Québec formulary. So when we do discuss CBS and the provinces and the health ministers approving, we're not excluding Quebec. We are merely not mentioning Quebec because they have their own health system. So great question. I want to be mindful of time. So I want to thank you, Dr. Chapman, for your time this evening. And thank you for participating in our short film titled Access for Alphas, which I'm excited to debut for our Zoom audience this evening. And we're going to move into that film now because I'm aware that it's 7:45. So I would encourage everyone to stay tuned for the announcement of our campaign following the movie.
I'm Kenneth Chapman, Professor of Medicine at the University of Toronto, and we're here in my research lab where we research lung diseases, including alpha-1 antitrypsin deficiency.
So my name is Lyle Malenka. I'm a respirologist working here in Sherwood Park at the Synergy Respiratory Center.
My name is Bruce Ritchie. I'm a hematologist in Edmonton. I've concentrated on the rare blood disorders for the last 30 years or so.
I had a full-time job, worked in the construction industry. I was very active with my kids, coaching their team. You know, they get it, it's not my fault. For the government to take the only thing away that these people had is just sickening.
I am the mother of 4 boys, the grandmother of 2, and the first 20 years of my working career were spent as a registered nurse. And the last 17 or so, we've been running our own business.
I do renovations and woodwork. I opened my company about 7 years ago. I have a 3-year-old son named Warner. We're expecting our second child in June of this year.
I realize that it is a genetic disease, and I had both of my adult children tested, and they have both tested positive. And I also had my brother and sister go, and my sister has also tested positive for the alpha-1 gene. So
we estimated years ago that between 5,000 and 8,000 Canadians have the full severe deficiency, alpha-1 antitrypsin deficiency. That figure of 5,000 or 8,000 makes it a rare disease, but one of the more common rare diseases. About the same prevalence as, for example, cystic fibrosis.
These people develop quite severe lung issues at a fairly young age, 40s, 50s, and it really does impact quality of life and longevity.
It's scary because basically when he gave me the diagnosis, he's like, well, you have, at the rate you're going, you have about 10 years left. Or, he's like, there's this treatment that we're going to apply for, which is this alpha-1 protein therapy.
it's proven to help. But how now how can you actually just sit there and go, okay, well, no, I'm sorry, we can't do this for you. You won't cover a drug that, yes, it is expensive. It's also saving lives. And if my treatment were to stop, my biggest fear, of course, is the lung function declining and eventually to the point where my lungs just won't work anymore. My kids and my grandkids losing me. I would just really like you to just rethink what you're doing to people and their families, not just the people themselves, but their families.
My treatment is ending because the clinical trial I'm involved in is ending, and I cannot afford the cost. We are going to need to relocate to British Columbia, where treatments are covered. Apparently, there's no guarantee in my mind that it would be accessible. So that would be my biggest concern, is that I've done all this.
These diseases are more costly if you allow them to progress, and if you treat them in an effective way, as we do in our rare blood disorder clinic, then I believe we're able to take people who would be tax consumers and actually turn them into taxpayers. So that's a big change for them, big change in their confidence and quality of life, but also a big financial difference for society.
I find it hard to explain why treatment is not offered to people, or why they don't have access to it, quite frankly.
I can't work, I'm on disability. You know, every single thing that somebody takes for granted, it's not so easy for someone with alpha-1 antitrypsin.
The clock is ticking. As we see our patients with alpha-1, we see the growing disability, the increasing obstruction, the increasing need for oxygen, and certainly at my center, ultimately, for many of our patients, referral for lung transplant. So avoiding payment for augmentation therapy now does not ultimately avoid very costly medical interventions.
Treatment does mean you can continue your life in a normal manner, and you don't have to fear everything ending in 5 to 10 years.
So we have sold our house in Blueville, Ontario. We've sold our business, but if at some point it was covered by Ontario and I could move back, that would be huge. Well, family.
I'm sometimes embarrassed to speak to my colleagues internationally about alpha-1 antitrypsin deficiency. Canada, as it turns out, lags well behind other G7 nations, nations with wherewithal and resources. We are not only slow to make the diagnosis, we are very poor at offering treatment. And yet, if I look at countries like Germany, which have developed the structure of managing alpha-1, they aren't treating enormously high numbers of alpha patients. In other words, if Canada simply did what other developed nations did, we would not see a tremendous increase in the cost of care. And by the way, I use Germany as an example, but I could use Brazil as an example. I know that if you are discovered to have alpha-1 antitrypsin deficiency in Brazil, struggling Brazil, you will be given the treatment you need for your genetic condition. That's a country that recognizes we should not disadvantage people with a genetic problem. Canada talks a good game. It doesn't deliver.
I'd like to thank all the patients who, again, were so brave to share their stories with Mikhail Sorokin, the filmmaker out of Edmonton, Alberta, who we've been working very close with in recent months, and to Dr. Chapman and all the physicians that not only treat alpha-1 patients, but who advocate on their behalf. We need you, and we value the support from the medical community. Now it is time to help us get access for alphas. This evening, we are announcing a call to action and launching a new microsite at www.accessforalphas.ca. This site is a tool just for you, the patient, the family member, friend, neighbor, colleague, and concerned citizen, and doctor. On this site, You merely enter your name and region, and a letter of support to get access for ALPHAs will go directly to your local elected official and to your Minister of Health. You can opt to include your story about living with Alpha-1 or just send the letter as it stands. We will be revising the letter every 6 to 8 weeks to reflect the status of the category review process. ALPHA's microsite is an easy-to-use online advocacy tool. This microsite can be used by anyone to inform your local elected official that you support access to augmentation therapy for all severely affected Canadian Alpha-1 patients. This online advocacy tool is asking elected officials to recognize that it is time that an augmentation therapy category be included on the Canadian Blood Services Plasma Protein and Related Products formulary. Simply enter your address, name, and email, and then by clicking the send letter icon, your letter will be sent to both your local elected official as well as your provincial or territorial health minister. As it stands today, we are imploring governments to give interim access while we wait for the review to conclude, because the lung destruction that patients will experience during the review process is irreversible. Please share this new website with everyone you know, and please reach out to us if you would like to share your personal journey with Alpha-1 via video patient testimonial. I'd like to thank you for taking the time to tune in tonight and ask that you continue to check in and visit www.accessforalphas.ca for updates and newly released videos. We also can't thank those enough that took the time to complete our patient and caregiver survey, as well as giving up a couple hours on a Saturday to participate in one of our focus groups, and to the over 3,000 concerned citizens that signed our petition. We look forward to providing another virtual event with some updates in November for Alpha-1 Awareness Month. These events and our work could not happen if it were not for our generous funders. So I would like to thank our core sponsors, Grifols, CSL Behring Canada, Takeda, and AlphaNet Canada, along with the countless patients that support our mission and cheer us on. Please know that there is hope, and Alpha-1 Canada is committing to improving the lives of alphas. Thank you and good night.
Bonjour, je suis le visage d'Alpha 1.
We are the faces of Alpha-1.
I am the face 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 of Alpha-1.
Je suis le visage d'Alpha 1.
I am the face of Alpha-1.
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 I am the face of Alpha-1 antitrypsin deficiency.